Welcome to Pediatric Case Review Musculoskeletal Series. Today we present a case-based clinical review of osteochondritis dissecans in children, designed for general pediatric physicians. This lecture covers clinical presentation, pathophysiology, diagnostic imaging, treatment strategies, and complications. We will work through 14 carefully crafted clinical cases. Let us begin. Case 1. Progressive knee pain in a young athlete. A 13-year-old male soccer player presents to the clinic with a 3-month history of progressive right knee pain. The pain worsens with running and jumping, and he reports occasional episodes of the knee giving way during games. He denies any specific traumatic injury. On examination, mild joint effusion is noted with localized tenderness over the medial femoral condyle. What is the most likely diagnosis? Option A, patellofemoral pain syndrome. Option B, osteochondritis dissecans. Option C, meniscal tear. Option D, Osgood-Schlatter disease. The correct answer is Option B, osteochondritis dissecans. This case demonstrates the classic presentation. Key diagnostic features include activity-related knee pain worsening with running and jumping, a giving way sensation which suggests fragment instability, medial femoral condyle tenderness, which is the classic location for knee osteochondritis dissecans, mild joint effusion reflecting reactive synovitis around the lesion, and insidious onset with no specific traumatic event. Clinical Pearl. Osteochondritis dissecans accounts for up to 29% of knee pain in active adolescents, with peak incidence between ages 10 and 17 years and a male predominance. The most common site is the posterolateral aspect of the medial femoral condyle. Case 2. Elbow pain and mechanical clicking. A 14-year-old female gymnast presents with 6 weeks of intermittent left elbow pain. She reports a clicking sensation during overhead movements and has no history of trauma. Physical exam reveals tenderness over the lateral elbow and mildly reduced range of motion. Which anatomical site is most commonly affected by osteochondritis dissecans in this clinical scenario? Option A, olecranon. Option B, radial head. Option C, humeral capitellum. Option D, medial epicondyle. The correct answer is Option C, the humeral capitellum. The capitellum is the most common site of elbow osteochondritis dissecans, particularly in gymnasts and overhead-throwing athletes. Gymnasts subject the lateral elbow to repetitive compressive and valgus forces during weight-bearing activities, compromising blood supply to the capitellum. The capitellum also has a precarious end-arterial blood supply, making it susceptible to ischemia and subchondral bone necrosis, which is the hallmark of osteochondritis dissecans. Classic symptoms in this case include lateral elbow pain, mechanical clicking, reduced range of motion, and tenderness over the capitellum, all of which are the signature findings of capitellar osteochondritis dissecans. Clinical Pearl. Always obtain an early X-ray as the first-line investigation in this presentation. Case 3. Chronic ankle pain post-trauma. A 15-year-old male recreational footballer presents with persistent right ankle pain for 6 months following a sports-related sprain. The initial sprain was treated conservatively with rest and bracing, but pain never fully resolved despite physiotherapy. Current symptoms include deep, aching ankle pain worsening with activity, intermittent joint locking sensation, and occasional swelling after prolonged walking, with no fever or systemic symptoms. Examination reveals mild anterior ankle swelling, tenderness over the anteromedial talar dome, restricted dorsiflexion, and no ligamentous laxity on stress testing. Based on this clinical presentation, what is the most likely diagnosis? Option A, sinus tarsi syndrome. Option B, tarsal coalition. Option C, stress fracture of the distal fibula. Option D, talar dome osteochondritis dissecans. The correct answer is Option D, talar dome osteochondritis dissecans. Ankle osteochondritis dissecans commonly follows a prior sprain or trauma. Even a minor injury can disrupt subchondral blood supply, leading to avascular changes in the talar dome. Classic clinical clues in this case include an adolescent with chronic ankle pain persisting after a sprain, mechanical locking and catching which suggest a loose or unstable osteochondral fragment, and pain that is worse on weight-bearing and activity. The most common site is the posteromedial talar dome, followed by the anterolateral talar dome. Clinical Pearl. Always consider talar osteochondritis dissecans in any adolescent with ankle pain that persists beyond 6 to 8 weeks after a sprain, especially if mechanical symptoms are present. Case 4. Physical examination. A 12-year-old boy presents with a 3-month history of right knee pain that worsens with activity. There is no history of trauma. On physical examination, the knee is flexed to 90 degrees. The tibia is internally rotated, and the knee is slowly extended. Pain is elicited between 30 and 90 degrees of flexion and is relieved when the tibia is externally rotated. Which physical examination test is being performed? Option A, Wilson's test. Option B, Lachman test. Option C, McMurray test. Option D, pivot shift test. The correct answer is option A, Wilson's test. Wilson's test is a classic clinical maneuver used to identify osteochondritis dissecans lesions of the medial femoral condyle, which is the most common site of knee osteochondritis dissecans in children. How to perform Wilson's test? Flex the knee to 90 degrees. Internally rotate the tibia, then slowly extend the knee toward full extension. A positive test produces pain appearing between 30 and 90 degrees of flexion, and that pain is relieved by external rotation of the tibia. Clinical Pearl. Wilson's test is not pathognomonic, but is a useful bedside indicator. Always correlate with magnetic resonance imaging for definitive diagnosis and lesion stability assessment. Case 5. Interpreting joint effusion and crepitus. A 14-year-old male presents with a 6-week history of right knee discomfort that has gradually worsened with physical activity. He is an active football player with no history of acute injury or fever. On physical examination, localized tenderness over the medial femoral condyle, a small non-warm joint effusion is palpable. Subtle crepitus is noted with passive range of motion, no ligamentous laxity on stress testing, and the patient is aporexial with no signs of systemic illness. What do these physical examination findings primarily suggest about the underlying pathology? Option A, synovitis. Option B, unstable osteochondral fragment. Option C, septic arthritis. Option D, ligamentous laxity. The correct answer is option B, unstable osteochondral fragment. Joint effusion in osteochondritis dissecans occurs when synovial fluid accumulates in response to cartilage breakdown and subchondral bone stress, representing a sign of advancing disease. Crepitus, which is a grinding or crackling sensation with passive motion, reflects roughening of the articular surface or the presence of a partially detached or loose osteochondral fragment within the joint. Together, these two findings indicate the lesion has progressed beyond the early stable phase and may represent an unstable or detached fragment, which is a critical clinical turning point. Clinical Pearl. Crepitus plus effusion in a young athlete equals osteochondritis dissecans unstable stage until proven otherwise. Order magnetic resonance imaging urgently. Case 6. Pathophysiology. What drives the osteochondritis dissecans lesion? A 12-year-old male presents with a 4-month history of progressive right knee pain worsening with physical activity. There is no history of acute trauma. Imaging reveals a well-defined subchondral defect in the medial femoral condyle with surrounding sclerosis. Laboratory workup, including inflammatory markers and cultures, is entirely normal. Histological analysis of the lesion shows evidence of bone necrosis and disrupted vascular supply to the subchondral region. What is the primary pathophysiological driver responsible for this osteochondral lesion? Option A, acute fracture of the subchondral plate. Option B, genetic mutation affecting collagen synthesis. Option C, subchondral bone ischemia and necrosis. Option D, primary bacterial infection of bone. The correct answer is option C, subchondral bone ischemia and necrosis. Repetitive microtrauma, which is common in young athletes, causes cumulative stress on the subchondral bone. This disrupts the local blood supply, leading to ischemia and subsequent avascular necrosis of the bone beneath the articular cartilage. The cascade follows this sequence. Repetitive mechanical loading overwhelms the bone's repair capacity. Vascular compromise leads to localized subchondral ischemia. Necrosis weakens structural support for the overlying cartilage, and cartilage softening leads to partial detachment and then loose body formation. An important note, in skeletally immature patients, the subchondral bone is especially vulnerable due to active endochondral ossification, making repetitive sport activity a key risk factor. Case 7. Initial imaging selection. A 13-year-old competitive soccer player presents with a 6-week history of progressive right knee pain. The pain worsens with running and jumping activities. Physical examination reveals mild joint effusion and localized tenderness over the posteromedial aspect of the knee. Clinical suspicion is osteochondritis dissecans. Which radiographic view is most sensitive for detecting posterior femoral condyle lesions? Option A, lateral view. Option B, sunrise view. Option C, anteroposterior view. Option D, tunnel notch view. The correct answer is option D, the tunnel notch view. Posteriorly located lesions on the femoral condyles are often invisible on standard anteroposterior views. The tunnel view tilts the beam to reveal them by projecting the intercondylar notch. Weight-bearing views stress the joint and may unmask subtle subchondral changes not visible at rest. The standard initial X-ray series for suspected knee osteochondritis dissecans is anteroposterior view, lateral view, and tunnel notch view. Bilateral X-rays are also recommended because asymptomatic contralateral involvement is found in up to 20 to 30% of cases. Clinical Pearl. The tunnel view is the single most important additional view when knee osteochondritis dissecans is suspected. Never skip it in a young athlete with knee pain. Case 8. Assessing lesion stability on magnetic resonance imaging. A 14-year-old male with a known right knee osteochondritis dissecans lesion diagnosed 4 months ago presents for follow-up. He reports persistent pain despite 4 months of activity restriction, with occasional locking of the knee during daily activities. On examination, mild effusion, tenderness over the medial femoral condyle, and limited full extension. A magnetic resonance imaging of the right knee is performed to reassess the lesion. Which magnetic resonance imaging finding is most indicative of an unstable osteochondritis dissecans lesion? Option A. High T2 signal rim around the fragment. Option B. Subchondral sclerosis beneath the lesion. Option C. Bone marrow edema in adjacent bone. Option D. Cartilage thinning over the lesion. The correct answer is Option A. High T2 signal rim around the fragment. On magnetic resonance imaging, a high T2 signal rim surrounding an osteochondritis dissecans fragment is the most reliable indicator of lesion instability. This bright signal represents synovial fluid tracking behind the fragment, separating it from the underlying subchondral bone, which is a sign that the fragment is no longer biologically attached. Other magnetic resonance imaging signs of instability include a fluid-filled cyst beneath the lesion suggesting undermining of bone, a breach in articular cartilage indicating the fragment may be partially loose, and fragment displacement indicating advanced instability or a loose body. Clinical Pearl. Magnetic resonance imaging is the gold standard for osteochondritis dissecans staging. A high T2 signal rim on coronal or sagittal views is the single most important sign of instability and directly influences the decision to proceed with surgical intervention. Case 9. Staging and classification. A 14-year-old male football player presents with a 6-month history of right knee pain that has progressively worsened despite rest and activity modification. Magnetic resonance imaging report findings include an osteochondral lesion at the medial femoral condyle, high T2 signal rim completely surrounding the fragment, partial detachment of the fragment from the underlying bone, focal cartilage breach with early separation, and no free fragment identified within the joint space. According to the hefty magnetic resonance imaging classification of osteochondritis dissecans, which stage does this magnetic resonance imaging report most likely represent? Option A. Stage 1, stable. Option B. Stage 2, partially unstable. Option C. Stage 3, unstable. Option D. Stage 4, completely detached. The correct answer is Option C. Stage 3, which is unstable. The hefty magnetic resonance imaging classification system has 4 stages. Stage 1 is mild with no signal changes and intact cartilage, indicating a stable lesion. Stage 2 is moderate with a partial high T2 signal rim and cartilage breach, indicating partial instability. Stage 3 is severe with a high T2 rim completely surrounding the fragment and no bony attachment, indicating an unstable, detaching lesion. Stage 4 is advanced with a loose body and full separation, indicating complete instability. In this case, the complete T2 rim plus focal cartilage breach plus early separation but no free fragment equals Stage 3. Clinical Pearl. Magnetic resonance imaging is the gold standard for staging. Stage 2 lesions in skeletally immature patients may still respond to conservative management. Case 10. Treatment strategies. A 10-year-old boy is brought in by his parents after an incidental finding on imaging obtained for an unrelated reason. Radiographs reveal a small, well-defined subchondral lesion in the medial femoral condyle of the right knee. He has no knee pain, no swelling, no mechanical symptoms, and no restriction in range of motion. Magnetic resonance imaging confirms a stable, intact cartilage surface with no fluid undercutting the fragment. He is skeletally immature with open growth plates. What is the most appropriate initial management for this patient? Option A. Immediate surgery. Option B. Casting and immobilization. Option C. Activity modification and observation. Option D. Total bed rest. The correct answer is Option C. Activity modification and structured non-operative management. In skeletally immature patients with a stable osteochondritis dissecans lesion, The growth plate is still open and the bone retains significant healing potential. Non-operative management is the evidence-based first-line approach centered on activity modification, avoiding high-impact loading for 3 to 6 months to allow spontaneous reossification and lesion healing. The non-operative management protocol includes activity restriction, avoiding high-impact sports for 3 to 6 months. Partial or full weight bearing is tolerated with crutches if painful. Optional knee brace for comfort and protection. Physical therapy, focusing on range of motion and quadriceps strengthening. Follow-up magnetic resonance imaging at 3 to 6 months to assess healing. And return to sport only after confirmed radiological and clinical healing. Healing rates up to 50 to 94% are reported with conservative management in skeletally immature patients with stable lesions. Case 11. Indications for surgical intervention. A 15-year-old male soccer player has been managed conservatively for an osteochondritis dissecans lesion of the medial femoral condyle for 6 months. Despite strict activity restriction and physical therapy, he continues to experience persistent knee pain with daily activities, intermittent joint swelling, and mechanical catching during walking. Repeat magnetic resonance imaging shows no signs of healing and suggests possible lesion instability. His growth plates are nearly closed on imaging. What is the strongest indication for proceeding to surgical intervention in this patient? Option A, patient preference. Option B, lesion size less than 1 centimeter. Option C, age greater than 10 years. Option D, failure of conservative management. The correct answer is option D, failure of conservative management after 3 to 6 months in a symptomatic, skeletally immature patient. In skeletally immature patients with stable osteochondritis dissecans lesions, non-operative management is always the first-line approach. Surgical intervention becomes indicated when conservative treatment fails after 3 to 6 months. The lesion shows signs of instability on magnetic resonance imaging. There is a loose body within the joint where symptoms are persistent or worsening despite rest. Clinical Pearl, skeletal maturity is the single most important factor guiding the transition to surgery. Open growth plates suggest higher healing potential, so conservative options should always be exhausted first. Case 12. Advanced surgical techniques. A 13-year-old male competitive basketball player has an 8-month history of persistent right knee pain. Despite 6 months of strict activity restriction and conservative management, follow-up magnetic resonance imaging shows a stable but non-healing osteochondritis dissecans lesion on the medial femoral condyle with no signs of fragment separation. Skeletal growth plates remain open, no mechanical symptoms. Full range of motion is preserved. Cartilage surface appears intact on imaging. Which surgical procedure is most appropriate to stimulate healing of this stable, non-healing lesion? Option A, retrograde drilling. Option B, total joint replacement. Option C, fragment excision. Option D, synovectomy. The correct answer is option A, retrograde drilling. Retrograde drilling is the preferred technique for accessing osteochondral lesions while preserving the articular cartilage surface. The mechanism of action involves creating channels for revascularization, promoting healing of subchondral bone, stimulating bone marrow cell migration, and maintaining cartilage integrity throughout the procedure. The retrograde approach is preferred because it preserves the articular surface, allows precise lesion targeting, minimizes cartilage damage, and promotes the natural healing response. Clinical Pearl, drilling depth should be 6 to 8 millimeters into healthy subchondral bone to ensure adequate revascularization without compromising joint stability. Case 13. Long-term complications of osteochondritis dissecans. A 25-year-old male presents to the orthopedic clinic with progressive pain and stiffness in his right knee for the past 2 years. He recalls having knee pain as a child around age 12, which was never formally evaluated or treated. He reports no history of trauma, infection, or systemic illness. On examination, mild joint effusion, reduced range of motion, and crepitus with passive flexion. X-ray shows joint space narrowing and subchondral irregularity of the medial femoral condyle. What is the most likely long-term complication of untreated pediatric osteochondritis dissecans in this patient? Option A, bone tumor. Option B, early onset osteoarthritis. Option C, chronic infection. Option D, muscle atrophy. The correct answer is option B, early onset osteoarthritis. When an osteochondral lesion fails to heal, the articular cartilage loses its smooth, congruent surface. This irregularity disrupts the normal load distribution across the joint, creating focal areas of abnormally high mechanical stress. The cascade that leads to joint degeneration includes articular surface irregularity causing focal stress concentration subchondral bone loss reducing cartilage support and nutrition, loose body formation causing recurrent mechanical joint damage, and synovial inflammation accelerating cartilage breakdown. The result is premature osteoarthritis, especially in skeletally immature patients with large or unstable lesions. Clinical Pearl. The risk of early-onset osteoarthritis is significantly higher when osteochondritis dissecans lesions are large, unstable, or treated late, underscoring the importance of early diagnosis and appropriate intervention. Case 14. Associated conditions and risk factors. A previously healthy 11-year-old boy is brought in with a 4-month history of lateral knee pain that worsens with running and stair climbing. There is no history of significant trauma. On examination, there is mild effusion, tenderness over the lateral femoral condyle, and a subtle snapping sensation felt during passive knee flexion and extension. X-ray and subsequent magnetic resonance imaging confirm an osteochondritis dissecans lesion of the lateral femoral condyle. The treating physician suspects an underlying structural predisposing factor may be contributing to this atypical location. Which condition is most frequently associated with osteochondritis dissecans of the lateral femoral condyle? Option A, genu varum. Option B, hip dysplasia. Option C, discoid lateral meniscus. Option D, scoliosis. The correct answer is option C, discoid lateral meniscus. A discoid lateral meniscus is an anatomical variant where the meniscus is abnormally thick, disc-shaped, and covers a larger portion of the tibial plateau than normal. The enlarged, irregular meniscus alters load distribution across the knee joint, creating abnormal contact pressures on the articular cartilage and subchondral bone. Repetitive abnormal loading concentrates stress on focal areas of the femoral condyle, predisposing the subchondral bone to ischemia and osteochondritis dissecans lesion formation. Children with discoid meniscus and osteochondritis dissecans often present with lateral knee pain, a palpable clunk, and mechanical symptoms, distinguishing this from typical medial condyle osteochondritis dissecans. Key associations with pediatric osteochondritis dissecans also include varus and valgus malalignment, obesity due to increased joint load, and repetitive high-impact activity. We would like to take a moment to introduce you to the Pediatric Case Review community on Patreon. This platform gives you access to all lecture videos organized by organ system, including musculoskeletal, respiratory, and beyond, so you can find exactly what you need, fast. Every slide from every lecture is available to download as photos, so you can review, annotate, and study at your own pace. The community also includes all case-based questions from our lectures to reinforce your knowledge, which is perfect for clinical preparation and continuous learning. If you want to join, simply comment below this post, and we will personally message you with all the details. We have now completed our case-based clinical review of osteochondritis dissecans in children. The 4 key takeaways from this lecture are: first, early recognition matters. Vague activity-related pain in active children warrants osteochondritis dissecans consideration. Second, image to confirm and stage. Use X-ray first, then magnetic resonance imaging to assess cartilage integrity and lesion stability. Third, individualized treatment. Stable lesions respond to conservative care, while unstable lesions require surgical intervention. Fourth, prevent long-term damage. Timely management prevents early osteoarthritis and joint degeneration. Please follow Pediatric Case Review for more evidence-based, case-driven lectures on pediatric musculoskeletal disorders and beyond. If you have a question or feedback, drop a comment below. We personally respond to every message, and your questions help shape our next lecture.